most common, I'm going to discuss lumbar disc herniation with radiculopathy. One of the main bread and butter aspects of any of us who practice in the arena of spinal pathology, spine problems. And I see our list of attendees is really across the swath of specialties, whether it's internal medicine, neurosurgeons, orthopedic surgeons, physical therapy, radiology, PM&R. We really have the full gamut. So I hope that my talk will address some of those issues in helping to simplify this. One of the things I always step back on, even though I'm one of the more senior surgeons here, I always like to quote Hippocrates, which again, sometimes we need to step back and just take a deep breath and not rush into surgery. So I always like to quote this old guy. Another cartoon illustration here summarizes it too. Sometimes we can be so excited to fix things that we may lose sight that a lot of times these problems can actually resolve themselves to some extent on their own. Maybe it's not cured completely, but they may be non-surgical or get better with conservative care. So as we all know, back problems and back pain is one of the most challenging problems in the entire medical profession, because so many people get it. A large percentage get better with very minimal to no treatment, and a very small percentage require any type of urgent, much less surgical treatment. So before we get too involved in it, I'd like to step back, just illustrate a case here. This is a maybe typical person that would present to almost all of us. A younger male, has a couple months history of back problems. The physical exam is fairly benign, does have some unusual symptoms in that he complains the pain bothers him all of the time and may even be worse at nighttime, really denies most constitutional symptoms. So the physical exam was pretty benign, but on the x-ray, it had kind of a small abnormality, and even to a seasoned radiologist may be missed initially, but if you cone in on it, you see that there's a compression of one of the vertebrae, and it's a little more sclerotic, seen in the middle there. So once I saw that, as well as the fact that generally younger people without any evidence of trauma wouldn't be that often to have such a worsening back problem, we did get an MRI scan, and it ended up showing a very large compressive lesion in the spinal canal, occupying almost the entire thoracic vertebrae as well. So despite not having any presenting neurologic deficits or even neurologic symptoms, he had a very severe problem that warranted essentially emergent or urgent intervention. And as we were doing the workup that very day, the patient ended up developing quadriplegia. By the time we were getting him finished with a lot of the studies, we were originally planning to do the surgery early the next morning, but that changed when he became acutely paraplegic. So we actually took him to surgery that night and did a thoracotomy, corpectomy, decompression of the spinal cord. And fortunately, he did improve neurologically, albeit had still a bit of a foot drop on one side. The pathology ended up coming back as a metastatic seminoma, and the urologist ended up doing part of their procedure that evening as well, which was a orchiectomy as part of their definitive treatment. So sometimes patients may present with kind of benign findings, but you should be alerted that they sometimes still have serious problems. So it is important to take a detailed history and look for any of those red flag symptoms. I put this up. This is just a picture of what cancellous bone should look like. So if you take out the bone material from the vertebrae and it looks like this, which is essentially epithelioid type mutated cells with a lot of abnormalities, and it's not bone that looks like this, then you've got a big problem. So again, another type of scenario where an older female has a history of back pain, no radicular symptoms, no history of trauma. Sometimes those folks still have a compression fracture, even without significant trauma. So again, what I'm going to discuss is a little bit on the epidemiology. We're going to focus on the radiculopathy and lumbar disc problems because they are the vast majority of the problems, whether it be a disc herniation, which I'm going to focus on, or the lumbar degenerative disc disease, which Kieran just gave a very comprehensive talk on. So again, going back to history, it is pretty amazing that we were able to diagnose herniated disc before we even had MRI imaging. This is a study report by Mixter in the New England Journal in 1934, where he basically correlated the physical exam findings of a herniated disc, meaning radicular or referred leg pain, from a disc spinal pathology. These are physicians back in the day who really relied on the history as well as a very detailed physical exam to make a diagnosis. At that point, doctors did not have the luxury of having all these advanced imaging studies that we have today, but it's still, I would stress the importance of a very good history and physical exam. As we said, the incidence of back problems is extremely high, and the prevalence in a population is also very high, both in Nachemson's study, which is from Sweden, and even from Rick Deo's study here in the United States. Even though it's a small percentage that go on to have lumbar spine surgery, it's still a large percentage of a population when you're talking about 1% to 2% of an entire population that ends up ultimately in their lifetime having a back surgery. Fortunately, the overall prognosis is excellent, and the vast majority, as we've said, certainly initially can be treated without surgery. Really, the select few reasons for an urgent surgery are spinal cord compression that we saw before, or if there is a large compressive lesion, whether it's from a disc herniation or some type of other problem where they have muscle weakness, neurologic deficit, or bowel or bladder dysfunction from an acute compressive lesion, which we would refer to as cauda equina syndrome. Those are really the few types of problems that would require an urgent surgical treatment. Most of the time, again, these happen usually happen because of a traumatic finding, but occasionally, as we saw, there are some cases that happen due to non-acute issues. So what are the causes? Well, again, most common cause of back problems and back pain is going to be ligamentous soft tissue problems. But as Kieran pointed out, the degenerative process of both the disc, and we didn't spend as much time on the facet joints, but there's a large percentage of folks that still have facet joint problems as well. I'm not going to get into all of the basic science since Kieran did it, but what I'm going to focus on is what a disc injury or disc herniation protrusion can cause for the patient. So this is an illustration cartoon of where the most common locations of a disc herniation, disc protrusion is. As you can see, it's in this posterolateral region that will affect what we call the traversing nerve root below the named vertebral level in a disc herniation level. Occasionally, the disc will migrate in a cephalad direction, causing compression of the exiting nerve root at the above level, or even a far lateral herniation. Occasionally, in rare cases, it will completely separate from that disc level, migrate, and have a sequestered fragment that compresses in another spot. On the axial cut here, you see how it tends to compress the nerve farther out. So usually when you have radiculopathic symptoms, it's going to be confined to one side or the other. Again, this is the MRI imaging showing how the disc is extruded at that one level, compressing the neurologic elements posteriorly. As Kieran pointed out, there's a pathologic process. Sometimes people get a degenerative process that may in turn lead to an annular disruption and a herniation, or it can be the annular disruption and herniation that ends up initiating the degenerative process. Again, lots of risk factors for back pain or discogenic problems. Which areas of the profession see the problems? Well, again, as the subspecialist here in the tertiary care center, we tend to see more of the compressive lesions that cause the neurologic problems, whereas in the internal medicine and family medicine realm, they're going to see all of the patients presenting with usually a back pain, non-specific, undiagnosed, and be the ones at the front line to have to be tasked with diagnosing the precise pain generator. When it comes to the treatments, again, we generally would always prefer and often do the non-operative treatments, as Kieran has already pointed out. It will take a very focused and thorough history. A lot of times we want to define how much back pain a patient has versus the percentage of leg pain. If it's more of a radiculopathic leg pain, then we're worried about a compressive lesion compressing either the nerve root or the spinal cord itself. And certainly the associated symptoms can help us key in to decide, is there some type of tumor or infection, other things like that. Usually the red flag symptoms are going to be these weird kind of symptoms or pain out of proportion to the problem: night pain, fever, chills, night sweats, or other symptoms such as bowel or bladder dysfunction that may have come on at the same time. On the physical exam, again, just assessing the gait, their ambulation, doing a focused motor and sensory examination, testing for reflexes. Again, for lumbar disc problems, we really do want to know what the straight leg raise test is. A contralateral straight leg raise test will often have the highest predictive value that they do, in fact, have a herniated disc that is compressing. Clonus is going to be testing for an upper motor neuron problem. Some patients may be even so severe where they're tilting off to the side. They can't walk upright very well because the disc is compressing the nerve so severely, they tend, in an effort to lean to the other way, to avoid the compression. In an axillary herniation, they tend to lean towards the side of the lesion. We also want to decide and try to assess, is there actually a neurologic deficit, or is it mainly because of the pain that they're reluctant to give their full effort? So again, do we need to do an MRI? Well, certainly if there's a neurologic abnormality, or if they have the red flag symptoms, or a long-standing back pain that is unrelenting and not going away. Sometimes you will have to order some of the laboratory tests, blood tests, if you're suspecting some medical issues or infection. So again, when it comes down to the treatment, we often will try all the non-operative treatments. What I don't like to do is just tell a patient to live with it or stop running or stop doing the activity. I want to treat the problem. So I'm steadfast in prescribing the physical therapy. I do advocate for other modalities, whether it be chiropractic, acupuncture, OT, all of the things we can do to try to have patients avoid a surgery or the invasive treatments if possible, with the little asterisk, again, unless they have those red flag symptoms that would warrant more urgent treatment. After the simple treatments, medications, therapy, conservative things, we often rely on our interventionalists to try some type of injections, nerve blocks, epidural injections. And we do try to send people to the top non-operative specialists as well to have the best results. In an effort to save a little time, I'm going to cut some of this short. I am a strong believer in injections. A lot of times those are very successful at helping patients with acute disc herniations and problems. They're not nearly as effective for chronic severe problems of arthritis, severe spinal stenosis, some of the other problems we see in the spine center. So when it comes to surgery, again, when it's a disc herniation, there's a handful of options. The traditional, more dated technique would be an open discectomy, where a full laminectomy, laminotomy, medial facetectomy with a discectomy. This is more invasive. Again, still has a very good outcome because it generally will excise the discogenic lesion, but tends to involve more of a stay in the hospital and have more postoperative pain, at least in the short term. The traditional surgery that I and my colleagues usually employ are going to be a microlumbar discectomy, where it's a small incision using some of these specific retractor systems and using an operating microscope in order to make a very small, minimally invasive approach, still excise the disc under direct visualization and provide an excellent outcome. Other techniques include endoscopic discectomy or laser discectomy. The problem is some of these have pros and cons and some limitations. As I've said, the discectomy surgery is very effective at relieving the pain. The problem is with an open discectomy, the incision and muscle and tissue inflammation is much more extensive than doing the microsurgeries that I and most of our colleagues do in today's day and age. I'm going to skip to endoscopic discectomy. It's not my procedure of choice, simply because there are a little more risk, mainly because you have to direct the trocars down to the level. You're doing it a bit blind, meaning not under direct visualization. You're relying on generally fluoroscopy to get the trocars and ultimately the endoscope into the field where you can visualize it until you get to the disc and you see the nerve right there. The problem is if you inadvertently direct it into the nerve to begin with, it can have untoward effects and some risk of nerve damage. So to me, in my hands, I feel more comfortable doing the microdiscectomy. Laser discectomy is very similar to the endoscopic, except it also uses a laser, but the drawback to this is it usually is better at relieving and treating small disc bulges that do require treatment, because as you see, you're usually going into the disc and treating it from an inside out technique, which limits you in number one, retracting the neurologic structures in order to excise a large herniation, as well as having some risk when you first direct the trocars that it could in fact impact the nerve root or neurologic structures. So the problem with this is, in my opinion, it does have a role. However, it's very narrow for small, persistently symptomatic disc bulges, which generally is a very, very small percentage of the disc herniations that require surgical treatment. Moving on to microdiscectomy, which you see here, it usually involves using some type of specific MIS type retractor to get you down to the level under direct visualization. A small laminotomy is performed under direct visualization, and then you directly see the nerve root as you looks like we got caught up there. Let's see if I can go back. So as you see here, I'm retracting the nerve under the direct visualization of the microscope. You see the piece of disc there. It looks like a big juicy piece of of crab meat or lobster, and we're going to excise that very carefully while protecting the nerve root. You see the pulsatile, thecal sac, and nerve root adjacent to it. We're going to be very careful to retract that, retract the nerve root and excise the piece of disc fragment that's impinging on the nerve root there. So we expect excellent results of this. Most of the people can resume their full activities. Even the highest level of sports is what is expected. So as a summary, certainly the 99.9% of disc problems can be treated initially without surgery. If you are worried about some of these unusual circumstances, additional advanced imaging is warranted. Thank you very much for your time.